I'm calling the health meeting to order here at 20 minutes after 1, and Chief Joe Bird is going to ask an occasion for us.
Let's go to our Creator. The most gracious Heavenly Father, thank you for this day. Thank you for the opportunity to take care of the business of our nation. Thank you, Lord, for the many blessings you have given us, and thank you for the veterans, and thank you for the leadership of this tribe. Thank you for the leadership of this country. Be with them, dear Lord, as they make difficult decisions that affect our country. Thank you, Lord, for our tribe, and we just have a look over us this meeting, that we may make the best decisions for our people. In Jesus' name we pray. Amen. This is not set up right.
Push back on the end of wash.
Shelley, will you call the roll, please?
Yes, ma'am. Janelle Fulbright.
Present.
Dick Lace.
Here.
Jack Baker.
Here.
Carly Buzzard.
Here.
Joe Bird.
Honey.
Julia Coates.
Here.
Jody Fishinghawk. Tom Bartman. Hannah Glory George.
Present.
Franklin Target. Present. Lee Keener.
Honey.
Curtis Snell. Janice Taylor. Here. David Thornton. Victoria Vesquez. David Walkenstick.
Honey.
Kara Callan Watts.
Honey.
We do have a quorum.
Thank you. I'm sure everyone has had time to look at the minutes, so at this time I would entertain a motion for their approval.
So moved.
Second.
We've had a motion and a second. All in favor of approval, let it be known by saying aye. Aye. Any opposed? The minutes are approved. We'll go right into reports, and first is Claire Moore and Mr. George Valuers.
Good afternoon.
Good afternoon.
The MRI is up. We are putting patients through it. We're taking consults from within the facility first, getting them scheduled. Any scheduled appointments after that should be available to outside facilities and outside referrals. Chiropractor is still running smooth. We're going to sit down this week and look at extending his or renewing his contract. Outpatient visits dropped a little bit, but we met our 3% for the year of collections. We have a new surgeon started from OSU. He's a contract surgeon. We should have another one starting within a month, and that will put us up to 4 staff surgeons. The ER contract is getting put in place. We should have docs. The scheduled date is December 1st to start. We're going to try to get them on, bring them on, and actually start scheduling shifts for them earlier than that, as soon as we can get them credentialed. So that's looking really good. We just hired a family practice doc from Pawnee. His name's Dr. Lopez. Actually, he's an internal medicine doc. He starts next week and shouldn't take much orientation. He's been in the Indian Health Service in the system, so shouldn't take much orientation, so he should be up and seeing patients pretty quickly. You had asked for these for some numbers broke out by tribe. I turned those in to get approval to give those out, and they haven't given that to me yet. So as soon as I get that, those will start being on the report. If I get them in between reports, I can send them out by email.
Thank you.
So I haven't forgot. I just have to get those approved. Any questions?
Any questions? Yes, go ahead.
Thank you, Madam Chair. Thank you for the report on the MRI. Mm-hmm. And is everything still going well with our marshal service? And
yes.
Any response by the Claremore Police or whoever's involved? That relationship still good?
Everything's going well.
Very good. And then I've gotten some feedback that maybe we've had departmental problems on like OBGYN or one or two? Did you clear the air, and or do we have any departments that have lost so many positions or
Well-
something that they're,
Dr. Hilliard retired, who was the chief of service, and there's been an adjustment reassigning his patients to other OB-GYNs, but we have one contract OB-GYN already started, and we have 2 more going through credentialing right now, so it shouldn't be
so
very
you
long.
think it's a very temporary,
Yes.
and you've already identified that it's an issue and you're moving forward?
Absolutely.
So,
Yes,
very
ma'am.
good. Thank you, George. I appreciate it. Thank you, Madam Chair.
Thank you. Yes, go ahead.
Thank you, Madam Chair. What's the waiting time look like for chiropractic care? The waiting list?
I think she told me there was less, it was down to less than 50 patients, so I would probably say just a couple of weeks, 2 or 3 weeks to get in.
Okay. Okay. Thank you. Thank you, Madam Chair.
Thank you. Counselor Buzzard, go right ahead.
George, I was looking at the admissions at Carmel Hospital again. It says an actual of 0% and 62 numbers per month. Is that how many admitted? 62?
The same, yes, 62 is admitted. And the 0% is there were 62 last year on the same month.
Okay. So there was 0 last year?
No, there was 60. There was a 0% increase or decrease. It was 62. Just happened to be 62 again.
And where are the other patients going? Are you contracting those patients out, or 62 sound like a small number to me, although I guess I should be happy they're not. I'm sure there's more patients that need care.
A lot of them are contracted out. There's the ones that come through the ER who need a higher level of care than what we can provide are transferred out to usually Tulsa through contract health. Yes, sir.
And what is your basic care there for admitting there in the hospital? Is it like flu or appendix?
It's basic things like appendix, basic surgeries, primary care. We've actually been going over what we would do if we had an Ebola patient come in. We've been training and drilling on that, I think, as has everybody. But our goal on something that severe would be to get them in and stable and get transferred up to Tulsa, where they're more able to care for somebody like that.
So what is the problem that we don't admit more there? Is it because of the lack of doctors that take care of patients that need those care that you're contracting out?
They're coming. What we're told by the docs is that the severity of the patients that are coming in, a lot of patients won't come in until they put it off until they just can't stand it anymore, and then they come in. Well, they have digressed to a point that they need more acute care than what we can provide. So in the patient's interest, we go ahead and ship them to Tulsa. Those that we can keep there, of course, we would rather have them there. But in the patient's best interest, we get them to the level of care they need.
Thank you, Mr. Chairman.
Anyone else? All righty, thank you for that great report. Appreciate it.
Thank you.
Next, our health director, Ms. Connie Davis, and I think she's got a special report here. She's going to have one of her doctors report to us.
We sure do. I've asked Dr. Mira, at your request,
Yes.
to come and give everyone an update on Ebola and our preparedness for addressing that. So, Dr. Mira, if you don't mind.
Good afternoon. Okay, I'll give you a brief summary, and I'd be happy to answer any questions if I can. So this Ebola is a virus which the last outbreak started in Africa. It's pretty much not under well control right now. And we've had in the United States several patients, some that got infected in Africa and were transferred to the U.S. for care, and one patient who got infected in Africa but presented with symptoms in the U.S., and that's the Dallas patient, the one who was admitted and died last week. The other problem is that this patient apparently infected a nurse that was in the hospital, and that nurse is being, treated in the hospital as we speak. So we have one patient developing symptoms in the U.S. and the first infection occurring, transmission in the U.S. In Dallas right now. What we've done at Hastings Hospital in Cherokee Nation is we mailed out a package to all the providers on the basic information specifically regarding how to screen for this disease in case a patient presents, and also how to protect themselves from getting the virus from the patient. And we had a meeting this morning discussing other aspects regarding what to do if we need to transfer a patient, EMS, where would we be placing the patient, and other strategic matters. So, I mean, that's, in a nutshell, a summary. If you have any specific questions, I'd be happy to answer them.
Yes, go right ahead.
Thank you, Madam Chairwoman. Thank you so much, because I think this is on people's minds. But from a logistical perspective, if I'm a family member or potential patient, or I'm at the facility, how long will it take us to respond in terms of, because I assume there is a tremendous amount of stuff that has to happen to isolate a patient that we don't necessarily have on site. Is that correct? How would it work? Like, what would the response time be? Who do we have them call?
Okay.
We're not 911, so them calling us on at 2 o'clock in the morning doesn't help them or the facility they're at. So what is the protocol we tell them about in general?
Okay, so as of until today, at least, the only way you can get infected is if you travel to Africa. So the first thing we're doing on all the facilities and the clinics is teaching the providers how to screen, which is a very simple question, is have you been to Africa in the last 3 weeks or in the last month if you want to be on the safer mode? Or have you been in contact with anybody who has been to Africa? And it specifically is West Africa, but we're just making it Africa to make it a simpler question, that has been sick. If the answer is no, as of today, there's no way they can have Ebola virus infection. If the answer is yes, each facility has a designated isolation room, and the provider is instructed to place immediately the patient on that isolation room and to manage the patient with protective gear that we have in the facilities. There's more sophisticated and less sophisticated protective gear, and we had a discussion this morning about that to see what level we needed, what places. But the basic gear, which is impermeable gown, goggles, a face mask, protective shoe wear, and we all have that right now. And so it depends if the patient's on a clinic or in the hospital. If it's on a clinic, they're instructed to put them in the isolation room, and then they have to contact us and EMS to assess the situation and provide to transfer that patient wherever it needs to be transferred if they're in the clinics. If it's in the hospital, they also have to call me or Dr. Miller, which is the internist that works with me, and I'm usually available 24/7, and we will guide them on what to do with that patient at that moment. The ER physicians have received a checklist in which, in case for whatever reason they can't reach me immediately, they have a checklist that was given by CDC, in which they have all the things they need to do with that patient concerning blood tests or contacting the state health department, the CDC, etc. So we have that in place. The critical thing is to make sure that everybody's screening the patients correctly, and that's what we're working on right now to make sure that happens.
And I can't recall if we had discussed this at the last meeting, but this is the same. George has this in place too for Claremore, correct? Everything's okay. Thank you very much for your time today.
Sure.
We appreciate you being away from
Thank you.
treatment.
Thank you, Dr. Mayor. And to follow up for what we're doing to help Claremore, we received a call from Admiral Meeks, Oklahoma City Area Office Director, earlier in the month requesting assistance for OB coverage at the Claremore Hospital. So we, within 1 week, facilitated Dr. Greg Woody going up there. He's a highly respected and former director of our obstetrics department, and he is up there assisting them with their OB-GYN procedures as well. And as a matter of fact, I spoke to him by text last week, and things seem to be going well on his part. Additionally, we'll be attending the board meeting at Claremore Hospital in the morning, and then we'll be meeting with their executive team, Dr. Grimm and Dr. Montgomery, Brian Hill and I, in the afternoon to see what other kind of support we can offer them during this time. Dr. Montgomery has some information on cancer that was requested to be submitted a couple of committees ago, but we ran over both times, so I'm going to ask him at this time to come present that, and then I'll follow up with the rest of my report, if that's okay with Madam Chair.
Good afternoon. Councilor Watts had presented me a paper from the Journal of the Oklahoma State Medical Association from April of this year that cited the cancer incidence staging among American Indians in Oklahoma. It had some what I would say are concerning findings. It said that the incidence of cancer among Indians and Native Americans in Oklahoma was significantly higher than the non-Indians. The other thing that it cited was that the incidence was significantly higher in Tahlequah compared to all other service units. The point that I want to stress about that paper, Councilor Watts, is those data, which were published this year, were from 2005 and 2009. So the data that I'm going to tell you about today that's included in this report is much more recent data. Okay? So again, I think you had legitimate concerns that were based on this paper, and hopefully will give you information that will reassure you. First thing to say, though, is that in looking at the incidence of cancer, where do the numbers come from? And again, what I'd stress is incidence means each year how many people are diagnosed with cancer and what kind of cancer they diagnosed with. And I'm just going to ask you to go to the second sheet, and we'll get back to the front of it, but the second sheet shows by sex, male and female, the different kinds of cancer. And then you'll see in blue and yellow, blue is Cherokee, and the yellow is what's called SEER, non-Hispanic whites. SEER is just the term used for the method that the data is collected. And this is a nationally recognized and approved and vetted way of collecting data and reporting data with regards to cancer. So again, you'll see males on top, females on bottom. And the important thing to note is that among men, prostate cancer is the #1 cancer, but among men, whites have a higher incidence of cancer than Cherokees when it comes to prostate cancer. In women, the #1 cancer is breast cancer. And again, among non-Hispanic whites, the incidence of breast cancer is higher than among Cherokee women. Are you following me? Is that?
Can we ask questions?
Yes.
Sure.
So, I can't recall the source of their data. But
Yep.
it was our data?
It was a combination of data from our SEER registry, our registry, and another type of data collection that's conducted in the state of Oklahoma.
So we would not necessarily be comfortable. There were probably box checkers, meaning those who claim to be Indian but aren't, and then there would be those who are Indian but didn't get marked as
That might have been an issue.
in mainstream.
And then the other thing I would emphasize is this data is as of June 11th last year. And even that report showed that the incidence was significantly lower comparing data from several years ago to more recent data. And so my conclusion is that we're doing a much better job, and the incidence among Cherokees is significantly lower than what it was from the numbers they reported in that study. Does that make sense?
Yes, did we look at overall data based on geographical residence?
That we have not
We
done.
would look to see if it takes out the box checkers and those that should be marked as Cherokee but
Right.
aren't.
In that study, they did have a geographic distribution. We have not done that with our cancer registry. We have not done a geographic distribution, nor have we done a stage at diagnosis measure. The measures that you're going to see cited in here are just the instance, the annual incidence by cancer diagnosis in the year 2013. But I still think it's important. We can say our overall instance is significantly lower than what was reported in this study.
Do you have any idea on, from our perspective, is that a ramp up in what we're doing in testing and screening process?
And that's the first page. So again, there are a variety of things that we do, but the important programs to mention are the Cherokee Nation Breast and Cervical Cancer Early Detection Program, which is a CDC-funded program. The principal investigator is Dr. David Gann, and the program coordinator is Angela Leach. And again, you'll see the number of screening studies that are performed and the types of screening studies that are done related to breast and cervical cancer. And this has been a very, very successful program that's been in place now several years. The second thing that's mentioned is the Cherokee Nation Comprehensive Cancer Control Program. This is also a CDC-funded program that began in 2003. Dr. Gann is also the principal investigator of that study, and Margie Burkhart is the program coordinator, and Greg Bilby is the program educator. And that, too, has been a very successful program at forming coalitions with groups outside of Cherokee Nation looking at screening and prevention of cancer among all people, but focused on Cherokees. And then I also just briefly describe our cancer registry, which is directed by Dr. Sohail Khan. It is the only native approved tribally operated cancer registry in the United States. And it is, again, a SEER program, which is a well-recognized method of collecting data and reporting that data. And then the thing I'd highlight, which I've tried to emphasize, is that bottom statement. The overall cancer incident rates in Cherokee Nation were slightly lower than among SEER program non-Hispanic whites. However, high lung cancer incident rates indicate that tobacco control is an important priority in Cherokee Nation. It is the one cancer in which Cherokees have a higher incidence than non-Hispanic whites. Again, that's lung cancer. And I'll put in one final plug, if I may, Ms. Davis. You may have seen this in the recent Cherokee Phoenix. There was a very nice article on the adult tobacco survey. It's a program to find out the smoking and tobacco use among Cherokees, Cherokee adults, in our 14-counter TJSA. We've done it one time in the past, but we're going to update those numbers and see what our smoking incidence rates are and patterns of tobacco use. And I'm very excited about that. That began in August, and the survey is going to be a much larger number. It's going to be over 4,000 adults that are going to be surveyed, and we should have that concluded in October or November. That, too, is also headed by Dr. Gann. He's a busy fellow, but he's a wonderful person to work with and does a great job. That's my report, Ms. Davis. Any other questions?
Councilor Coates?
Yes, thank you. I was looking at this, and what you said that in lung cancer is where we're higher, and also esophageal cancers. It looks like are cancers of the esophagus, which would also be smoking related, I think, right?
Yes. Uh-huh.
But there are two others where we're actually higher, as I'm looking at this, and that's in kidney and renal pelvis.
Yes, but those again
And
are
also
sorry.
in cervical cancers. Do you have any understanding or speculation as to why we are higher in those as well?
Well, again, I'd have to emphasize the incidence is very, very small. So it's a relatively small number, and the difference, although it does appear to be higher, may not be statistically significant with the numbers that are reported. And I'd have to get back to you on that. Does that, you know what I'm trying to say there?
Yeah.
Okay. The overall incidence of cervical cancer compared to prior numbers has gone up, and that is a concern, but I think we have a very robust and very focused effort to try to address that.
Thank you.
All right. Any other questions?
Councilor Watts?
Thank you. For cervix cancer, would that be HPV?
It is related to HPV,
Okay,
yes.
So do we have an idea of how often our female patients receive their annual exams? Because that would be the preventative measure, the screening measure, correct?
Yes, and there are very clear guidelines on when to begin screening and when to screen for HPV. It is a age-related phenomena, and we have very clear, those are national guidelines, and our providers are very strict in adhering to those guidelines. I hope that answers your question.
Well, I think one way to look at the system would be to see are all our female patients getting their annual exams. I've got anecdotal feedback from some folks that they're not getting in, or it's become difficult, or they're not reminded. I don't know how we do it within our system.
Our system uses the EHR as a tool. That's one of the advantages.
Electronic health record.
Yes, electronic health record. All providers get reminders on when to screen for the 3 commonest cancers, cervical, breast, and colon cancer. And those reminders come up in the process of doing their notes when they see patients. And these reminders also go to the nurses as they screen patients, so that the nurse and the provider, are joining in that effort then to address that notification when to screen and when to refer people for appropriate screening studies.
Okay, so I think, Dr. Montgomery, that is great for a portion of it, but what I think I've heard anecdotally is that it's the part where the patient comes in for their annual exam or whatever, that it doesn't get communicated for them to come in, or they feel like it's not communicated, or maybe they have trouble getting in for their annual.
I have not heard that complaint, because I know people, my family members or friends who need an exam, and they have the slot at Hastings particularly. They have a certain number of open slots so that drop-in patients can be accommodated or scheduled immediately.
I guess, do we ask them to go ahead and schedule their exam? I mean, how do the patients, do they just know to come and get it, or do they get a reminder?
No, this is integrated in part of the assessment when the nurse or the patient presents for care. You typically, as a nurse, take their vital signs, ask a chief complaint, what are your allergies, and there's these GEPRA scores that I'm going to give a very good report on next month, but there are certain things the government has always asked us to report, and that's part of the screening on every patient that presents to any part of our health system. And I'll report to you the specifics, but all of the screening tools, we receive some national rewards on our screening and completion of those. So I think the system is in place to, yes, identify those and communicate to the patient their need to have this screening.
Let me ask you a different way then. So George has tried to explain GIPRA to a lot of us when Claremore was going through it. And I don't know that I still understand it completely, how they measure for hospitals. It's only on hospitals, is that correct, GIPRA?
It's on the clinics also.
clinics.
It's on all over,
Yeah.
throughout the system.
So IHS use it as a scoring system essentially, and it's down to the
For
level of
quality.
detail, statistically review how each patient. And so when you say a patient presents themselves, that means they have to actively decide to go into the, this is what I recall from these discussions when we start measuring. So they're a patient if they have had one visit to, we'll pick on Hastings, in the last 3 years, is that correct?
They're considered an active patient.
They're considered an active patient, therefore measured in the GIPRA, whether they've only been there once or 500 times in 3 years.
I believe so, and Dr. Grimm, I'll defer to you.
Okay. So females don't tend, and I have no scientific basis to say this, I guess, but females tend to go to the doctor where a man would not. But even then, that's still not maybe the case. So preventative medicine is something in my family. I knew I had to go to the dentist every 6 months, and I needed to have an annual exam every year. That's the way I grew up, whether I paid out of my pocket or went to IHS. So, but that's not the case for everyone. So where I've had Cherokee women that I love pass away, it's because for some reason they were not getting pounded into them to remind them that they needed an annual exam. So I know you guys talk this every day, and so when you say patient presents themselves, they physically have to decide on their own to go to the hospital. Is that what that means?
Yes.
Yes.
So if I, 3 years ago, went to Hastings, and I live out somewhere, and I'm not thinking about getting an annual exam or whatever is going on, because especially like HPV and cervical cancer is hitting older women that may not feel like they need an annual exam anymore. I do not get reminded as an older Cherokee woman then to come get an annual exam, or even every 2 years if that's the new standard for gynecology.
No.
Okay, because that's what I was asking. So that is, we do not remind, and we're not actively getting in. See, and that's a measure of what I think is happening here, why that would be happening. So we may have internal steps that we're taking, which is great, and we need to do that. But we're also not getting them in and preventing, we could get early treatment, which we wouldn't lose our speakers and some other stuff I've seen. That would be my 2 cents. Because it seems to have negatively impacted some of our speakers. We've lost some women that.
Well, again, Councilor Watts, I would argue that the Comprehensive Cancer Control Program is an effort to get the word out,
Okay.
educate Cherokee citizens about the need for screening, and also with information that tells you when you should be screened. So there are a lot of ways of looking at that, but I think part of it is your focus and your education and trying to make people aware of what's needed. In the end, you have to have, I think the other program is very good about following patients up that carry that diagnosis. They have case managers that are dedicated to making sure that women don't fall through the cracks for needed follow-up. But I know what you're saying is trying to get those people who might not have otherwise thought of coming in for an exam to be reminded. And I do think that there are efforts that are trying to address that.
I think from the way I think I finally understand how we do that or don't do that, we're missing a final step at the individual patient level to get those women in. And I'm sure that we could cut down on the prostate cancer impacts and cost and deaths, because that's very preventable too, just like colon. If we were actively saying, hey, it's time for you to come in. And it doesn't sound like we do that right now.
No, there is no formal process to seek out those patients right now. There's no organized effort, I guess.
No.
I just think it's a missed opportunity if we're not doing that, especially if we have the system in place, the EHR.
We can certainly look to see.
I mean, at 50, or I guess let's say it's $1.50 by the time staff time and you process a letter and you do a bunch of stuff with a stamp. That's way cheaper than the other consequences later on.
Absolutely, it would be.
I'm still going to make the argument based on the numbers that we have, that with the incidence being substantially lower than the number that was reported in the study that you showed me, that our efforts are working. I don't want this to look as if we aren't addressing this and aren't trying to reduce the incidence of cancer among Cherokees.
I don't want to say that I don't appreciate what we're already doing.
Right.
But there may seem to be a lot of us, because we're all surrounded and we're one of the larger tribes and we know everybody around us is Cherokee, but we're really pretty few, especially when it seems to, I would guess, and I'm not looking at the data, I haven't analyzed the data, don't have the data, but I would guess that it significantly impacts our elders too, is my guess.
Well, again, I'm going to emphasize that the one cancer where we really do have a disparity is with lung cancer. All the others, we're very, very similar to non-Hispanic whites. So, and again, the incidence that was reported in that study showed me, I'll say it again, we've improved. And I think it's because of the efforts of people that preceded me in our current efforts. So, and that doesn't mean we won't continue to work harder and do better.
Well, I'm glad we're even having this discussion and that the health committee is doing something a little bit more clear maybe than usual, and this is exciting to me. So I hope that we hear more about what we're doing with cancer prevention and how we're doing on a regular basis. Thank you, Madam Chair.
I think we've got one more question, but I've got a comment just. With my experience at Redbird Smith, with my family, and we have continued care. They're very persistent, the cancer coordinator, to write you a letter in the mail, call you, write you a second letter and say, you have got to go to Stillwell for your mammogram. Same thing with my husband on his colonoscopy. The case manager called, wrote him a letter, told him he had to go report to Dr. Pablo at Hastings. He didn't want to, but he went. And he went up there for his consultation, and the surgeon said, no, you do not need another colonoscopy. But from the experience I've had, they've been on top of it and very persistent about making you almost go get your pap smear and your mammogram. And I think maybe part of it may be their scorecard system, that they are also being rated on how well they do these things, and they're very persistent about reminding you, and they will call you, and they will write you a letter, both, I know. So that's a concentrated effort on reaching people. I think, Dr. Coates, you were next, and then Councilor Buzzard.
I'm glad to hear you've had that experience. I was just thinking as I was listening to Councilor Watts, I was remembering I used to get in the mail annual reminders, and I haven't for a number of years now, for quite a few years. So I think we did used to do this at some point, but the only reason I know to go in for annual exams is because I write it on my calendar for for 1 year from now. I do it. If it wasn't for that, I'm not getting any phone calls, I'm not getting anything in the mail about it. And I do recall that I used to, both from Hastings and from Three Rivers, but haven't for probably 3, 4, 5 years at this point. So I just I'm glad.
And there's a number of things that can contribute to a breakdown in that. And, if you've had a change of address, a change of contact information, if that's not continually updated, we've actually had complaints.
At all.
Well, then we can certainly look into yours specifically. But, if that's changed, then that makes it a barrier for
But I guess maybe rather than looking into mine specifically, I guess the larger point on this is that it does seem to be inconsistent across our system, because Councilor Fulbright is having a much different experience than what I personally had very, very recently as well. That would be the larger systemic.
Please let me look into that and report back to you, okay?
Thank you.
All right, very good.
Councilor Buzzard?
And I think Councilor Coates has said what I was going to say, Dr. Montgomery, about now, maybe there are some things that we could do a little bit different. Although I like the numbers that they didn't come down last year. I think we can do a little bit better.
All right.
The other thing, and you have answered this for me, Dr. Montgomery, that did you look at community-wide, of where most cancer patients are coming to our clinics?
No, we have not with our cancer history. It takes personnel, and I will talk to Dr. Khan about it and see how readily and how easily that can be done.
I know these work here at the nation, we have reports, a lot of people from some communities says our cancer rate is just extremely high, and I think maybe it's from the electric line, power plant. It'd be interesting to see, if you can pull that information out and see where that stuff is coming.
I think the other word we use is there might be clusters. That's a word that's commonly used. But again, this data does not have it broken down by geographic area. It's just this is the total for the 14-county area.
And I think this is a good discussion. I think we're doing a decent job, but I think there's a little niche that we may be missing. So appreciate you guys.
These are good points and well taken.
Thank you.
Absolutely.
For Dr.
Councilor Lay, you're next.
Thank you, Madam Chair. I've got a couple of questions. There have been about 3 presenters, so just let me throw them out to you, Connie, and
Okay.
Dr. Gilman. We have a doctorate CIHS. Is that correct? I just heard him say that, I think.
Yes, we have,
Okay.
yes, an OB provider,
Okay.
yes.
And when did he or she go over there?
About 2 weeks ago, I believe.
Okay. Next time you do that, can you kind of send something out to us to let
Sure,
us know?
sure.
Especially those of us who are serving that area. Thank you. The Palladium contract is still ongoing?
It is.
I see back here in the back in your notes that you're going out to other hospitals for referrals, trying to get them to accept our referrals, I guess, and communicating with them.
Yes.
Didn't see anything about Barnesville.
We haven't met with them in a year or so. We've met with Benita twice in the last 3 or 4 months, and that's all the recent ones that I can
Off the top of
recall.
Oh,
my head, that's all I
We do meet with
recall.
Tahlequah City, but we can certainly circle back with Bartlesville.
Just don't want you to forget Barnesville.
We won't.
A lot of good doctors and a good hospital up there.
Yes.
The donut hole on Scripps, I've been getting some complaints, as you know, lately. I don't know that we're throwing them into the donut hole, but it seems to be happening. And if you could work up some guidelines or try to help keep these folks out of that, I'd appreciate it. That makes sense?
It does.
Okay, thank you. And I guess last but not least, our clinics that we're bringing online, clinics are preventative medicine. Before we had them, and I don't know about Hastings because I didn't live here, Claremore, they were so deluged with people that they, quite frankly, couldn't do preventative medicine. You were sick or needed a surgery when you went there before they let you in, before they would deal with you. Hopefully it's gotten better. I haven't been to Claremore personally. I know I've had some nieces and nephews born there in the last few years, so, I think they've come up a little bit. But without these clinics, we wouldn't have preventative maintenance or medicine, same thing. Like Janelle was just talking about. Something I've talked with Dr. Montgomery, each of these clinics operates totally separately, differently. Hers is sending out letters and almost harassing people to come and get checked, which is wonderful. Mine is not. Just throw that out to you guys, okay? When's that going to change?
I don't know that it's not happening, but I will clarify with Ms. Collins what their process is, because it's much of this is automated. So we'll find out.
The containment room that I heard the other gentleman speak of a while ago, where would you do that in the Bartlesville Clinic? Or in fact, where's the containment room in the NOAA Clinic?
Well, again, that word is isolation room, and I'm going to have to reach out to the medical directors and address that with each one of them. But you're right, in Bartlesville, it's not quite as easy. Because
out the back door.
But it will be a challenge. But we recognize that we've got to have a clear plan to have an isolation room. It's very easy to come up with a plan, relatively easy to come up with a plan at the hospital. It's much more problematic at the clinics for the very reason you said. So, but we have to do this, and we're going to work with all the medical directors to accomplish this the best we can.
And then a general statement would be the patient would be isolated in the room they are to prevent contamination of any other patients or staff in that area, and leave them confined to that specific room for their health care. Isolate them and the staff that's taking care of them with universal precautions that are practiced by all healthcare members, hopefully. And then it would be terminally cleaned once that patient was discharged from that
Well,
room.
I can't see how you do it at Bartlesville. I can't even see how you do it at NOAA because it's, as you know, it's a horseshoe. So
Yes.
people are going to be passing that contaminated room until somebody shows up to get the patient. Anyway, hopefully that'll never happen. Probably never will. The other thing is we ran out of water
I saw
in
that.
Milwaukee County.
Saw that.
Nobody came up to save us that I'm aware of. Yep.
But as you know from our email correspondence, I did not know until late in the day because I wasn't on my email. I wasn't notified until I read my email. And so I think emergency management was involved. I saw on that
Could
string.
somebody coordinate or work or do something to figure a better system out or something?
I'd say one thing, that all the clinics have a protocol in place for whenever things like that happen, and they implement it. It happens on a somewhat regular basis, that a city's water will shut down for a period of hours or a day or two, and we have protocols in place, policies in place for what they need to do to operate. And NOWADA did everything that they were supposed to do to get it started. Perhaps we should have notified you sooner that they...
I think I notified NOWADA.
They might not have known until they got there that morning, but whenever they come in, if there's no water, they have a protocol that they're supposed to follow.
I think Jay has functioned about 2 days without water last month, and as soon as we were involved, we had the facilities department here, along with the emergency management, transporting water up there, and they had the MOUs I talked to you about in the email with the local vendors.
I've seen the procedure, and it's a good one, but I don't think it's followed.
Well, then we'll do what they call a debriefing after any kind of emergency incident and see where we can improve things.
Okay.
Thank you.
Any other comments? Councilor Visor?
Comment back to Councilor Wade's comment about isolation rooms. And I take comment that a new clinic for building or do have those isolation
Yes.
rooms in, and then those particular rooms should be not connected to their air ducting system because it should have unpressurized air coming out of those. And I'm sure that's taken, but I'll check on that to make sure it is. I'm sure they've
Yes.
taken that into consideration. Okay.
And to clarify specifically for Ebola, as I understand it, it's not transported by air. It's direct contact body fluids. So putting them in a room, even such as one of the offices here, and gowning and gloving everyone that goes in and the patient would be appropriate.
Should be safe.
Okay. Thank you, Dr. Montgomery. Our EMS had their COAMP survey, which is a survey of their EMS education program, and they really did an outstanding job. I have a copy of that if I can share electronically if you'd like to see the report. I think of specifically Dr. Underwood, Jimmy Summerlin, Mitch Bright, and Dana Cavanis did an outstanding job. Our program director resigned about 2 days before survey, and they went ahead and pulled this off. And the only deficiency we found, or that was found, was good documentation of their clinical skills proficiency at final exam. So it didn't impact anything, and they've done a tremendous job. So when you see our EMS workers out there, give them a pat on the back. I have the report for Hastings average daily census for the month of August. The average daily census was 22. I have a breakdown of that. If you guys want it, I can send it to you electronically as well. I know we're probably running short on time, but in your packet, I'd just like to highlight the awards that the health system has received in blood donation, and some specific sites are recognized there. And as note, Wilma P. Mankiller donates to an Arkansas blood bank, and so that's why they weren't in there, if you notice that. The Indian QI Award for Outstanding Nursing has been awarded to the Hastings nursing staff. There's a very detailed explanation of what you have to achieve to get that national recognition, and it includes quality, which of course in our minds is always important, but it also talks about leadership in the terms of turnover and retention, and then the skill mix of the nursing staff there. So Valerie Rogers and Sandy Taggart and the staff at Hastings should be commended for that. Press Ganey is a patient satisfaction survey conducted by Medicare, actually, or as a representative of Medicare, required for inpatient hospitalizations. It's publicly reported data, and on page 12 of your report, you will see, and I think all of you would be happy to see, that Hastings, in almost every category, outscores even our region. And these aren't numbers that can be questioned or challenged by any. We can't skew it because it's selected by a Medicare number. So I think that you guys should be very happy and commend the staff at Hastings for that work. Councilor Watts, I know you had asked for a report on diabetes, and I'm going to give that next month on some of our efforts there. Three Rivers, something kind of fun, had hosted a live remote by the sports animal in the middle of the day show, Al Jerkins. And I don't know if you guys listen. Joe, you probably do. But we have had such a unbelievable and unpredicted response by people who listen, calling in and talking about their access to health care and how getting in to see their doctor helped diagnose their diabetes, helped diagnose their heart disease. And Chuck Smith from Three Rivers called me last week and said, one guy called in and said, that just got me to thinking, and I went to your smoking cessation classes, and I've gone 30 days without smoking. So there are prevention efforts out there that are working, and it's good on our part to hear in a venue like that, not something organized and, in our daily work, to hear those things. And the whole public, the entire public that listened, got to hear those stories, so we were pretty excited about that. Bonita Health Center, we've extended those hours from 7 a.m. to 5:30, except holidays and weekends, so we're hoping to improve access there at that clinic as well. Report on the ER and urgent care at Hastings for August, 6,332 patients were seen. Left without being seen rate of 5.7 in the ER, 4.4 in urgent care. And I think Councilman Jordan wanted to know a turnaround time. The average was 148 minutes, so we're getting close to our goal of 141. Behavioral health is still doing a remarkable job. I can't say enough about the staff that have done so much work to improve access. You'll see in the report that we saw 1,823 patients, and of those, 1,127 were unduplicated, and 995 were Cherokees. Jack Brown Center, hopefully you guys have this on your calendar. Their grand opening is this month, October 27th at 10:30. If you have not, please come out and see this beautiful facility that we've got for our kids. Cherokee Elder Care, the PACE program, has 129 participants, 60 employees. I think the most we've had there is 130, and that's close to capacity for that program right now. And I think that concludes my report.
Thank you. Councilor Watts, go ahead.
Thank you. Mr. Chairman, could you explain who this Arthur Holbert guy is and what seems to be going on in behavioral health, why we're having such a
The
loss?
improved access?
Well, I mean, we seem to be having a loss of staff. I'm confused about what's going on and why this non-Indian guy is involved. And
He's contracted to look at access. We've talked about him on and off about going in and evaluating our systems and helping put in scorecards or processes to improve access to our patients. In primary care in the last year, with his support and efforts and recommendations and working with our staff, we've already increased access to the primary care clinics by an average of about 2 patients a day. While that doesn't seem like much, that makes a tremendous impact when you multiply that times the number of providers, roughly 200. That times 2 every day is a big impact on our health system.
And I appreciate that part. Will his staffing firm, I guess, get to replace these Cherokees that have left now? Or
He has a physical therapy company that has contracted with the tribe for many years, and we do have some of his staff on contract.
But they're PT, they're not behavioral health?
No. He doesn't offer those services that I'm aware of.
I'm probably going to have more questions. I just haven't had time to get everything together. Thank you. Thank you, Madam Chairwoman.
Councilor Garvin is next.
Thank you, Madam Chair. I just want to say thank you to Dr. Montgomery and Dr. Graham and Connie and Brett for helping with this family in Muskogee. It's a critical situation, and it's going to take a lot of work to take care of it, but I'm thanking you in advance for what you're going to do. Appreciate it.
Thank you.
Councilor Keener.
Thank you, Madam Chair. Just to follow up on the question on behavioral health, the person or company on contract, they're just there to evaluate what's going on, so to speak, as far as seeing patients?
What Access to Health, I believe, is the name of his company. And what he has done is come in and looked at, we started with primary care. We've looked at our surgery department. We looked at physical therapy, actually, is where we started. And we've moved on and looking at areas that we feel like there's a high demand and we're not getting patients in. And he and his efforts were a big part of removing 500 patients from a wait list in behavioral health. And so when you're asking people to do a little more or do something different than they've done it for several years, you're going to get complaints. But overall, the staff has really embraced this, and again, they've done a good job making sure our patients are getting the needed care in behavioral health.
And that's the physical therapy part of it was lacking or was needing to be help?
Yes. I mean, I think everyone in here would agree we need better access to all of our services. And he started with physical therapy.
And then his company has that on the side?
He has a physical therapy staffing company as another business that has contracted providers.
So how's that contract made? Did it go out for bids, or because he's the consultant, he gets the contract?
No. The contract for staffing was in place long before I was even here.
But how does that work?
It's two separate contracts.
How does his company get the contract? How do they afford it?
I believe it's put out to bid.
Put out?
This year, I believe what we're doing with the staffing contracts is that we put out what our needs were across all facilities, and we're being allowed by the contracting office to select more than one provider, because we're not sure one provider can meet the needs across the whole 14 county area. So we put it out like that, put it out for bid, and then based on the needs of each facility, if one locums firm can meet 2 or 3 of our clinics, we'll choose one for this area, one for over here, maybe one for this type of provider. Not all of them carry all types of providers, so
Yeah.
but that's how we do it.
So that company would be one of many?
We have it for physicians or providers, nursing staff, that kind of thing.
And also, just to put it in perspective, there's 2 PTs in the whole system with this company. So, and then we actually have 2 Cherokee Nation hires taking their place. But we may keep these. We've had really good luck getting rid of the contract health waiting list for PT. So we may keep those contracts on for a little bit longer. We just about got our waiting list down, at least in Hastings, down to 60 total. And it's less than a month wait.
And Dr. Montgomery, are you the acting department head?
Yes.
And are we actively seeking, because I know it's not fair to Dr. Montgomery, it's not fair to the department, it makes him even more busy, but is there an active search?
We've talked to 2 or 3 who have sought us out. We wanted to change a few things, update the job description, which we've done with everything in health, or it seems here lately. And so I know I signed off, that was on this morning, wasn't it?
Yes, ma'am.
So that'll be posted hopefully within the week, and we can begin to interview within the next couple of weeks. Yes, we're ready, and I know Dr. Montgomery is too.
And then below Dr. Montgomery, are those clinical people next in charge?
Yes.
Or non-clinical?
Yes.
Clinical?
Well, there's an acting administrator this time, Connie.
Yes, of course.
Who is clinical?
I'm sorry, I didn't.
I'm the acting clinical director at this time.
Yes, but then underneath you, are those clinical people or non-clinical?
Yes. There's a combination of people, actually, but yes, most are clinical.
Mostly?
Yes.
So 70-30 or? Thank you. Thank you, Mr. Chair. Madam Chair.
I skipped. Were you, Dick Clay?
Yes, ma'am, just
Were you-
one, thank you.
Okay.
I'll put
Then Councilor Coates.
electronic health records. Where are you at on that?
We're moving along. We're doing well. We're waiting, I'm sorry?
Where's Dr. Stalk at that?
He could be
During these meetings,
anywhere,
load him up
and
take
I would
him
be
back
glad to
Noah.
bring him up here, but you may regret that request.
Don't bring him up here, I'll load him up and take him back to Noah. Thank you.
Dr. Coates?
Thank you. Honey, I was in for my annual exam last week, and I was told by the providers there at that time that they have been told that in the near future they have been instructed to begin scheduling in 10-minute increments of time rather than the 20-minute increments that they're presently scheduling.
That is absolutely inaccurate.
So the healthcare provider who told me this, and that a number of people there who were upset about it are mistaken.
They're mistaken. Something has been clearly miscommunicated.
Okay.
And what that probably stems from, we have to establish a scheduling packet for the new electronic health record. And so that was presented at the Medical Executive Committee last week for discussion. And that's a very vocal group, and overall was relatively well received. So there's no plan for a 10-minute visit that I'm aware of.
No.
So thank you.
Okay, well, I went to my appointment. I checked in. It was a half hour before anybody saw me. The nurse was with me for about 5 minutes, taking vitals and stuff like that, and then it was an additional 25 minutes waiting for the PA to come in for about a 3-minute exam. So I was there for an hour, and a total of 8 minutes of that time was actually spent with providers, actually doing something. So that was the reason that I began questioning, because I've never had that kind of experience. Now, Counselor Watts tells me, well, that's about what it is out in private practice, so that may be, because I haven't gone out to private practice for a long time, but that's certainly longer, much longer than I have ever waited before at this particular clinic and at a Cherokee Nation facility. So that was the reason that I began questioning, is it a shortage of providers here? Is it an overscheduling problem? Just to try to find out what, because again, this was my personal experience, and, just to see what might be going on, so.
I will forward that complaint, because I agree that's too long to wait.
Well, it's not a complaint. I mean, I want to say the providers are doing an excellent job. I'm not complaining about them. What I'm trying to get at is that if there is something systemic that is happening, because the providers, once I was with them, they were calm, they were patient, nobody seemed hurried, they gave me, every minute I wanted, they were there, responding. The care was good and so forth. But, there just seemed to be something. And I was told also that even with the 20-minute increments, that they're going home, taking work home and doing 3 or 4 more hours at night, because they don't have time to get to reports, to entering data, to looking at labs, to, things like this. So I don't know if this is just one person, or it didn't seem like it, because I did talk to several. It's not like they all said the same thing, but it's like putting it together. This is sort of the picture that emerged for me. This is one visit over a number of visits over many years. But it was quite a different experience than
And every
than the really
provider
efficient sort of service that I've had at our clinics in the past. So
every provider we have manages their schedule a little bit differently, and something we're trying to do is have continuity throughout the health system, so that however it's done in Salisal is done at Nowata, is done at Hastings. And in the new scheduling packet, there is administrative time allotted in that workday for the provider to help them plan and organize themselves a little better. So, and it's a work in progress, and see how it works when we roll it out in April and tweak it as we go along.
Okay, I appreciate it. Thank you.
You bet.
Thank you.
Councilor Snell? We have any other comments? Speaker
Well, I
Jordan?
went to the doctor last Friday at Hastings, and my appointment was great. I was in and out in 90 minutes, and that included getting my new medicine. So, and there was a whole room full, and they seemed to be moving along just really good. I mean, I know there's times when I've got on to you and said, why is this taking so long? Especially when someone calls and we've had a backup on Sunday afternoon in urgent care or something. But as far as our clinical situation, at least at Hastings, that's the only one I've been going to Hastings since I was born. And to me, the care and the amount of time that it's taking to get the care has never been better. But there's always room for improvements. All of us know that in the health field. You would like to be able to say the minute you towed in, isn't that what you call it, toe in, toe out?
Yes.
The minute that you tow in, you ought to be towing out. Well, that's not going to happen in reality. But I think you do a pretty darn good job, as best you can. I know I was real pleased the other day. I was also pleased with my numbers. So maybe I'll be around for a little while longer.
And that's another thing. Salina probably right now has the best toe-in, toe-out design that we have, and something that our quality management nurse, Ginger Glory, is working with Mr. Holbert, going clinic to clinic to see what's different here from Salina, and then we'll go back and roll out those changes. And there's some barriers, logistical things. Rooms, space is a huge part of it. And as they identify and do that assessment, we're going to start moving to make those improvements with all the clinics that are needed so that it's not that kind of experience.
Well, I will say, if I may, I went to radiology right after that, and I was right in. I imagine there was a phone call that had gone over there by that time.
Well, just as kind of another additional piece of information, I went the day before for my blood workup. Went right in, got in, they took my blood within 5 minutes, and I was gone. And it's happened not that way once, but a number of times in the lab. Very seldom do you sit in the lab there at Hastings more than a few minutes. It's excellent.
That's good. All of our healthcare employees, they work hard. There's over 2,000 of them that get up every day, and they want to go and do a good job. And every once in a while, you'll run into a few that aren't as motivated on a certain day. But overall, I think the over 2,000 employees we have do a tremendous job every day to take care of. It's proven in the data. It's proven in the numbers that we can't skew that data. That's all above us. And, we're going to fail every once in a while, and I'm sorry if we failed you, Ms. Coates.
Counselor Snell?
Oh, I don't look at it that way.
My sister Phyllis was in Hastings Hospital.
Yes.
She was there for about a week. But Hastings did do a lot for her. But they did tell her we've gone as far as we can go and send her to Hillcrest. And they did pull the life support about 5 o'clock yesterday afternoon.
Oh, I'm sorry.
But she's just at a point where she can hardly be helped. But the family was satisfied with Hastings. They did as far as they went as far as they could. The doctor did say, we can't go no farther with it. They sent her to Hillcrest. But long story short, she did good at, while she was in Hastings.
Thank you. I know you've had a rough year with your family.
It looks like we may lose her, but it's not, it's a health problem that they can't overcome. Thank you.
Thank you.
Any other comments? Okay. Thank you, Connie. Oh, I'm sorry.
I'm sorry. Connie, I do want to respond because to your comment, the system did not fail me. This is not what I'm trying to say, and I hope you understand that. The providers are excellent in our system. What you have here in your report is showing a customer satisfaction that, as you pointed out, a client satisfaction is well above what it is in the private sector. And when I make a comment and saying, hey, it's free, you didn't fail me, I'm not saying, well, it's free, so what do you expect? I'm saying this is something I tell people all the time when I hear a complaint is, you know what, you don't pay for this, and you're getting darn good service, and especially considering what healthcare costs are nowadays and that you're not paying a dime for any of this. This is excellent care. What I am saying is that I'd like to see us stay at the level that these stats show that we're at. And some of the things I was hearing the other day, and it's anecdote, and that's why I'm coming back and asking you about it, right?
Sure.
Because it would be of concern, I think, if we were heading systemically in a direction where those numbers began to drop, and we did end up being at a place that was comparable to the private sector that nobody much is very happy with. Right?
I agree.
And so I think that for us to have a level of client satisfaction that is as high as it is fantastic. So I want you to understand that's what I'm saying.
Okay.
And I'm sorry if it came across some other way, but I do want to check into some of the things that I was hearing, because if we were to go down some of these paths, I could easily see.
If we don't know about it, we can't fix it.
Into some problems. So I just wanted to
No, I appreciate
clear the
that.
air on that point.
Thank you.
For your responses. Thanks. Thank you.
Thank you, Connie. Next, we're going into old business, none pending, and new business, none pending, and announcements. And the next meeting is scheduled for Thursday, November the 13th, at 1 p.m. The chair will entertain a motion
Make a
to
motion to
adjourn.
adjourn.
Second.
All in favor of adjournment, say aye.
Aye.
We are adjourned.